Two, one. Sir, we are live now.
Good evening, everybody. Welcome again to today's webinar brought to you by the Orthopaedic Research and Education Foundation. Today, again, we have the pleasure of having Dr. Ananda Kisor with us from Kolkata, and he's going to talk to us the topic which is going to be introduced to you by Dr. Janki. So it's always a pleasure to have Dr. Pal with us. And over to you, Janki, to do the basic introductions.
Good evening, everyone. Welcome to the platform of Orthopaedic Research and Education Foundation India. Today we have Professor Ananda Kisor sir from Kolkata, and this is again one difficult topic, that question and answer which was asked last year. The difficult one sir will discuss today, and any confusion if related to this.
Please mute everybody who's...
Yeah, over to you, sir.
Yes. Good evening, everybody. Good evening, everybody. Thank you, Dr. John Mukhopadhaya, for his my scope of discussing this, because in the examination theory questions now just passed, we have came across. It is little bit just a newer type of questions, and they're OSCE also they're little bit different type. So we'll discuss one by one. So today we will discuss about the theory questions of the postgraduate orthopedic examinations. Now, this is a very, very important because you have to keep your brain. All of the students know is very well the theory, but as a time management and the management of the writing, art of writing, you have to learn because that will carry the marks. And if you don't follow this, if you make a just like a paragraph type of writing, so if in spite of writing everybody, you will lose some marks because it will be difficult to taking out your knowledge. So most important, we have to make the sections and the subsections in your writing, your khata. Okay, so these are the sections. Suppose in any disease or any topic, an orthopedic topic has come. So we have to go by this topic. This is introduction, pathogenesis, management, applications, and the treatment of this all the Now pathogenesis, it will come next, and if it is a trauma, then you have to go by this mechanism of injury, and there are different types of mechanisms we have to discuss in a brief. Next, you have to go by the classification, and then now come to the diagnosis. So if in this diagnosis part, so you have to discuss the history and the examination component. So in the salient history, you have to write as you are very much conversant during your practical examination, as also in the examination part. So you have to go by these the normal rhythm, like the inspection, palpation, movement, measurement, joint proximal, like this. So any points will come across, you have to write it down so that your the knowledge will enrich, your writing part will enrich. Now the management part, yes, there are three components. It will be same thing will be followed as you are following in your practical examination. Like how to manage your case, like this. You have to start your investigation to confirm your diagnosis, followed by plan of treatment, and followed by the prognosis. So investigation, then we have to start with the non-invasive, followed by the semi-invasive, and then invasive investigation. Followed by the plan, we can start with the conservative, semi-conservative, and the operative treatment. And then prognosis component, we have to discuss. We have to counsel. All counseling is very important, and then we have to write it down. The counseling, how to counsel the patients regarding the your prognosis, regarding the plan, and also what is your diagnosis. Now, lastly, the complication. If there is any complication, suppose if there is there's avascular necrosis of the femoral head, then the complication you have to discuss with the osteoarthrosis of the hip joint, and then treatment like the THR, like this. So this is very, very important. You have to make a sections and a subsection during your writing. Next, very, very important, you have to how to write. This is the art of writing. Is very important. So you have to keep the left side of your page empty, where you will write the name of the section, and they had to draw the diagram. It is very important. Draw any schematic type of diagram, you can write it down on the left side. And the right half of the page, you have to write everything. We have to write all the sentences, everything you have to write on the right side, keeping your left side free of this free space. And on the all the subsections, you have to go on the right side. You can use the multiple colors except the red one. You can use the red or the brown color during the drawing the diagram. And you have to use the flow chart, tables, and the schematic. Now I will show how to give this schematic diagram and the tables like this. So for this, I'll pick one topic from each paper, so that it is very difficult to discuss all the topics. So in this class, I'll picked up the one or two topics from each paper, so that we can cover all of these papers in a very short manner. So if you're very clever, and you can easily understand how will you cover. So there is a SARA. SARA is basically sexually acquired reactive arthritis. So basically a reactive arthritis triggered by a sexually transmitted pathogen in the genital tract. So sometimes it is some questions may be considered as very difficult, or it is not properly read by the student. So in that case, and the time is also very important. If the time is very less, you can write it in a concise manner. So suppose this only we have time only five minutes. So in that case, so these are the salient points. These are the salient points. You have to write it down in your answer sheet, so that you will get at least the pass marks. So what is that? It is a definition. It is a reactive arthritis triggered by the sexually transmitted pathogen in the genital tract. It may include the other systemic manifestations, including the tendons, fascia, skin, mucous membrane, and the eyes, like the trachoma, uveitis, irreversible visual loss. It is a sexually transmitted infection. That is why chlamydia in trachomatis, it is a 65% cases is involved, followed by the Neisseria gonorrhea. It is 16%. So most cases are the self-limiting and the resolve within 4 to 6 months, but 50% of the recurrent episodes and up to 70% as a chronic symptoms. Basic treatment is the NSAIDs and the antibiotics, and advise the patients about the safer sexual practices and the good food hygiene to avoid the potentially triggering infection in the future. So this is basically seen in those cases. So those are multiple partners, multiple sexual partners. So in a nutshell, you have to write it down if they don't have much time. But if you have a significant time, then you have to write it down like this. This is introduction. Basically, it is a risk of this predisposing factor of SARA is the gender. It is a main factor. So if it is a multiple partner, so among the male and female, male is much more important. It is involved in this category. There is HLA beta it is considered 10 times more common with this SARA. That is why in some cases the ankylosing spondylitis is also associated with this, and the HIV infection sometimes it is associated with this. Other spondyloarthritis, and there's basically this SAPO, there is a combination of the synovitis, acne, pustulosis, hyperosteosis, and the osteitis. It may be associated with this SARA. And this may be personal, the family history of spondyloarthritis. So basic feature you have, this is the three. This is can't see, can't be, or can't climb a tree. What is that? Basically, it has the conjunctivitis, that is uveitis. That is why there is a patient is easily unable to see. Patient has a non-gonococcal urethritis, leads to dysuria. That indicates can't pee, and is asymmetrical oligoarthritis. Basically, it is involved the axial joints. So I see in the axial joints. So that is why the axial joints and the large muscles are required to climb the trees or climb the staircase. So that is why the patients are unable to climb the tree. That is most important. So this is why this is not the classical triad. Now, how it differs from classic arthritis? Basically, it is an asymmetrical inflammatory oligoarthritis that is less than 6 joints, involving the large joint like the knee, ankle, I've already told, sacroiliac joint with or without swelling and stiffness, maybe migratory. Sometimes it involves also the fingers like the sausage fingers. It leads to dactylitis. It is a typical inflammatory in nature with morning stiffness and the nocturnal plane. And there are some other musculoskeletal and extra articular symptoms like the plantar fasciitis, enthesitis, tendonitis like this. And there are extra articulars, and basically I already told this irritable eyes. As you can see, this is a sarcinate balanitis. There is a geographic tongue, and there's keratoderma blenorrhegica. This is basically maybe say the less common symptoms are the malaise, fatigue, renal pathology, proteinuria, microscopic hematuria. Among the investigations, basically it is a radiograph, MRI, blood test, ESS, CRP, and HLA-B27. These are the most important. This column is most important. It is very, very useful for diagnosis. And the other, like the urethra surface, throat swab, arthrocentesis, synovial fluid analysis may be required. Now, management is basically, it is NSAIDs and the antibiotics. The rest orthotics, this basically it follows the common treatment principles and in other arthritis. Intra-articular corticosteroid injections may be used in a single troublesome joints. Mild skin and the mucous membrane infections do not require any specific treatment. Topical keratinolytic agents and corticosteroids may be used. Eye lesions may be managed with ophthalmological advice, and uveitis should be treated promptly. Otherwise, there is a significant scarring of the eyes. Now, in refractory cases, second-line therapies like the sulfasalazine, methotrexate, and azathioprine may be used. Most important is the prevention. That is, a partner notification is extremely important, from which the subject is patient is acquiring the infections, and we have to very much identify the partner, and all the patients should be advised to avoid all the sexual contact until they and their sexual partners have completed treatment. Less common therapies are the systemic corticosteroid and the other biologics. So prognosis, I already told, it is a self-limiting condition. Usually it usually completely cured within 4 to 6 months, but sometimes it is very, very it is progressive and leads to some chronic infection. So next question is the femoroacetabular impingement. So what is that? Before that, we have to learn about the combined anteversion. So if the combined anteversion, that is anteversion contributed by the acetabulum as also the femoral neck, if it is less than 40, then the flexion in internal rotation becomes limited, and that may be painful. And the edge of the neck abuts against the lateral acetabulum, that is the pincer, and the lateral edge of the deformity may abut the acetabular edge. Both can leads to this sort of problem. So this is why I have to put this picture, because it is very easy to draw in a schematic diagram. So this is the schematic. You can also draw this schematic. This is the acetabulum. This is the axis of the neck. So this is the anteversion. So this is the condyles. So this is the anteversion of the femoral neck. And see, this is the cup. So this is the anteversion of the cup. So basically, it is acetabulum. Same thing you can draw in your schematic diagram. It will so this is basically this anteversion of the femoral neck when in standing position. And this is the anteversion of the femoral neck in sitting position. So basically, both the combined anteversion is required in standing and the sitting position, and that can lead to this of aborting the acetabular. If there is the acetabular coverage is much more, that may come in the process of aborting against the femoral head, or if the femoral head is larger enough than the normal, and that edge of the femoral head may come in contact with the normal cup. So if the acetabulum is that faulty, that is known as the pincer, and basically this acetabulum is large enough, it is abnormal. And is a cam is the femoral head is large. So how do you remember? So basically aim is basically, it is a male, basically they are maybe big-headed. So big-headed male may become responsible for this cam effect. And another important, if it is a male, so there is a rapidly progressive, and if it is a female, so females are very slim. So that is why they're basically covered by their husbands or their superlatives. So that is why they are maybe covered by their outside, that is the acetabulum. Females are slim, so pincer effect is much more common in the female, whereas the cam effect is much more common in the male. And the female, they are very slowly progressive. Male, that is a cam effect, is a rapidly progressive. This is most important. And both the condition that can lead to groin pain ultimately leads to the degenerative arthritis. These are type of tables you can put in this manner. So the structural damage is the pincer type is labrum, whereas the cam effect is acetabular cartilage. As we've already told, this is commonly, pincer is commonly in case of female. Male is cam effect is much more important for the male component. First radiological sign for the pincer is the posterior inferior joint space narrowing. That is why we have to require a specific radiographic investigation. I will show what is that. And the cam effect is to anterolateral migration of the femoral head. So basically, it is a slow process in the pincer effect, and cam is a rapid process. So this is the true AP. So investigation is required a true AP. How to know this is a true AP? So this is a true. You have to write it down. The straight extra pelvis in both hip joint of both hip joint of true anteroposterior view, where the coccyx will almost touching the symphysis pubis. This is and the symmetrical obturator foramina. So this is the true AP. So in that case, you can identify the retroversion, and you can see the anterior rim of the vestibular process crosses the posterior. Anterior rim crosses the posterior, and there is a fatigue fracture of the femoral head. You can identify on this very clearly. And there's a cross-table lateral view. So in that case, if you usually identify the posterior and the anterior joint space. So this is very, very important to diagnose whether it is a CAM effect or the pincer effect. Another important higher investigation is the MR angiography. So and another there's a 3-TRESTA system is the DG MERIC, DG MRI. It is very important for the cartilage, which is can easily pick up the cartilage damage from out of this situation. And the treatment is basically, it is a conservative, it is the avoidance of the athletic activity, it's analgesic, cannot prevent this progression, whereas the operative is arthroscopic lavage, surgical self-dislocation followed by the anatomical labral refixation, correction of the femoral head, resection of the bone impediments, and correction of the osteotomy, corrective osteotomy, proximal femur and the sternum. So this is the how will you write it down. Another important topic is the rigid pace planners. So how do you know the pace planners? So basically, you have to write it down the anatomy of the longitudinal arch, medial and lateral longitudinal arch. And if we write it down this simple this diagram, simple the flow chart, so you can easily identify. So every information is given over there. Pace planners, it is a collapsed medial longitudinal arch, the medial longitudinal arch, and the heel valgus. It should be heel valgus. It's not a heel varus. It is a heel valgus, and that will lead to the prime. It may be primary or the compensatory. Primary, that how to identify. So patient will able to stand on tiptoe, and the jack test will become will show the there is recovery of the arch. And so if it is the medial longitudinal reappear, so it is a mobile component. If it is a medial longitudinal that doesn't reappear, that is a rigid component. So if it is a compensatory, so then it may be due to tight tender Achilles or the external rotational lower limb, and right tender Achilles may be constitutional or the neurological. So if by this test, stand on tiptoe and the jack test, the medial longitudinal arch reappear, so it is a mobile. If it doesn't reappear, it is a rigid one. Then again, it can happen in the infants and the older child. In infants, basically it is a congenital vertical talus. In the older child, it may be tarsal coalition, inflammatory condition, neoplastic, and the neurological disease. And you have to concentrate on a specific cause like this congenital vertical talus. I'm not going into detail. So these are everything you can found in your book, and you have to write it down. How will it? Painful accessory navicular, painful tarsal coalition. So these are the points to be discussed. Now the clubfoot. There's again the topic has come. This is a clubfoot is a relapse type of clubfoot. How do I identify? So basically in the introduction, we have to write it down. Basically clubfoot, maybe there are two types, maybe typical and the atypical. Typical, maybe there are several types like positional, delayed treated, recurrent, relapsed, and the alternative treated. So relapsed is coming under this situation. And the atypical may be rigid and resistant, syndromic, teratological, neurological, and the acquired. So relapse of the clubfoot, basic definition is the reappearance of any components of the clubfoot during the treatment, that is intervention and the follow-up in early, that is below 3 years, or the toddlers 3 or 4 years. Among the early and the toddlers relapsing is much more commoner than the early. So the basic treatment is the reappearance of the components of the clubfoot during the treatment, that is intervention and the follow-up. That is how we can write all the normal schedule of treatment and the follow-up. So this is the normal schedule and the follow-up. I'm not going into detail. All of you know what is the normal schedule. So this is you have to write it down in your relapse of the clubfoot, how it clubfoot appears. Now, cause of the clubfoot as per Morgan Day. So there are basically it can happen in two situations, where it can happen in well-treated and compliant baby, or in a non-compliant baby. So it is even in a well-treated compliant baby, it can happen, but it is the incidence is very less. There is 6%, and basically it is due to a persistent muscle imbalance that can lead to this sort of relapse. We have to identify it and we have to treat it and by most of the cases, surgical treatment is required. Whereas if it is treated completely with the help of the Ponseti, but the most important cause of relapse is the non-compliant baby. That is the parents, they actually losing their confidence to continue the use of these braces. That is how that leads to 80% relapses are due to non-compliant baby, non-compliant parents. Ultimately, that leads to because of the inadequate or not use of the brace, that leads to this sort of relapse. And in that case, we have to start the normal treatment, that is a Ponseti treatment, and most of the cases it will recover. So assessment, how to assess, how to clinically approach to the relapse clubfoot. So I already told it may be occur in the early, that is below 3 years, or in the toddlers 3 to 4 years. Most common is the toddlers relapsing 3 to 4 years. So it is early. That is most of the cases, the adduction and the cavus recovers, and it's the most important is the muscle imbalance that has to be properly addressed. Whereas in the relapsed toddler, most important is that we have to there are several causes of most is non-compliance. I've already told. So how to examine it? We have to examine the baby child in mother's lap or in the walking child. In the child in mother's lap, we have to examine the loss of the mobility of the joints, especially the subtarsal and the midtarsal or the ankle joint. So and that can lead to equinus, or in the subtarsal and midtarsal joint. If it is a very tight, that leads to adduction and the varus. Whereas in the walking child, if we have to examine the child when the child is going away, that means from the back. In that from the back, we can easily identify the heel varus in stance, and that leads to the varus deformity. Whereas if the child is coming closer to the examiner, we have to examine this dynamic supination only in the swing phase. So when the child is putting the foot on the ground, it is disappearing. That means it's a dynamic supination. So that is basically it is due to muscle imbalance. So how to manage these relapse clubfoot? We have to start the Ponseti casting weekly in the same manner till the correction of at least 50-degree abduction and 10-degree dorsiflexion. So if it is resolution occurs, then we have to come to the brace protocol as the normal Ponseti technique. But if it is not corrected, that means if the heel varus is the most commonest, equinus is the least common, the dynamic supination is the least common. So if the heel varus is the most common, so you have to do the operations depending on the age group. If it is a 3 years age group, we have to go by the lead blouse technique, 3 to 4 years Doyer's technique, 4 to 8 years Dillwyn Evans. That is just basically there's a reduction of the lateral column length, abnormal column of the lateral column. And in the 6 to 8 years, both the column, that is the lateral column plus the medial column, both should be addressed with the help of the Fowler's operation. So this is if the lead blouse, the anterior calcaneum is treated. 3 to 4 is Doyer's, it's a calcaneal shaft. It is a calcaneal osteotomy, mid-shaft calcaneal osteotomy, wedge correction. As the Dillwyn Evans, it is a calcaneocuboid wedge correction, wedge is taken out from the calcaneocuboid. Fowler's, both the sides on the lateral side, lateral column and the medial column should be corrected. If it is equinus, is the next common. Up to 4 years, Parkinson's tendo-Achilles tenotomy can be advocated. Above 4 years, we have to go by the soft tissue corrections by Tarkos technique, elongation of the tendo-Achilles by operation or by the GES application. Whether in the dynamic supination in the 3 to 4 years, you have to go by the tibialis anterior transfer. These are the common technique. Really, there is a metatarsal it is relapsed, and that requires metatarsal osteotomy by 5 years age. So these are the different we can draw this diagram. This Fowler technique, as you can see here, this is this wedge is correct, which is taken from the lateral border. So it is closed, it's a closing wedge osteotomy. This bone is taken on the medial side, and there's a medial cuneiform. It is linear osteotomy is done. It is opened, and that wedge is placed on the medial side. So this is the lateral border is this increased lateral border is corrected, and there's a concave short medial column is lengthened. So this is the Fowler's technique that can be done in a relatively elder age group. Now, this is the scoliosis has come, the adolescent idiopathic scoliosis. So in that case, as it is very good topic, also you will get in your examination, in the practical examination, you have to write it down, the onset, duration, progress, symptoms, pathology, like with abnormal gait, lack of coordination, bladder wall incontinence, like this. So in diagnosis component, these are the points to be included, whether it is a structural or non-structural, whether it is a number of curves, it is a single curve, double curve, or triple curve, location of the curve depending on the convexity, whether it is a right side or left, whether it is a compensated or non-compensated depending on the head, whether it is in the midline or is deflected, secondary factors, and the etiology. So these are the points to be examined in when you're in the convex side and also the concave side. What is scoliosis? Basically, it is the lateral curvature of the spine more than 10 degrees along with the rotation of the vertebra. Only simple lateral curvature doesn't theoretically cannot make it a scoliosis, may be considered as the least. Now, assessment may be due to the flexibility test, plumb line test, gait, limb length discrepancy, vesting we have to examine on the lower limb, hip, knee, ankle we have to examine, and all the obverse test should be examined. Idiopathic scoliosis, I am not going to detail because I have kept it because sometimes it may come in your examination. Where in examination, most important is the idiopathic adolescent scoliosis. Adolescent scoliosis, it has come. So we have to examine the how to examine it. So in that case, we have to rule out the spinal dysraphism, spinal imbalance in both the sagittal and the coronal plane. How to measure the spinal imbalance? I will also discuss limb length discrepancy, shoulder asymmetry, rib hump, waistline asymmetry, flexibility of the investigation is very important. Erect PA and the lateral full length radiograph of the spine. How it can be done? I will show you the bone age assessment for the detection of the skeletal maturity. Before surgery, we have to do the blood parameters, lung functions, heart functions, and the spinal cord status. So this is the Lenke classification of idiopathic adolescent idiopathic scoliosis. As you can see here, green is the structural, is a red, black is the no curvature. So black is the no curvature. Red is the structural, more than 25 degree curve angle in the lateral bending plane, major curve. Green is the structural minor curve. So these are basically the structural. Red and green is the structural curve. Blue is the non-structural curve or compensatory or the secondary curve. So basically there are 5 types. You can write it down. It's main thoracic, it's double thoracic, it is a double measure, it is a triple measure. So it's a triple measure curve. Basically it is a thoracolumbar curve where the lumbar is the main. It is a thoracolumbar curve, is the thoracic is the main. So the 5 types. So we have to select what is the principles of correction. Selective fusion of the primary curve, usually fusion, that is, this is spinal fusion of the primary curve, usually allow the spontaneous correction of the compensatory curve. Both the upper end to lower end of the vertebra, upper end vertebra to lower end of the vertebra should be included in the fusion. For the double structural curve, either fuse both the curves. Is a double, suppose it's a double structural curve. So either you have to fuse both the curves or fuse the lower one. And for the upper curve fusion, follow the guidelines of the Lenke. That means if the upper curve is more than 30 degree, corrects. If it is less than corrects up to less than 20 degree. If it is a more than grade 1 rotation of the apical vertebra, T1 tilt to the concavity and shoulder elevation on the convex side. So these are the options. This is anterior discectomy, instrumentation fusion, or the posterior instrumentation after removal of the facet joints, pedicle subtraction osteotomy, complete vertebrectomy, and fusion. So most of the cases, posterior instrumentation is used, and these are the conditions where you have to use, where you have to give the observation. We have to observe when you observe curve below 20 degree, non-progressive, non-cosmetic. You can observe. But if you have to use the brace protocol, the curve 20 to 40 degree with significant growth remaining, we can use the brace. Other we have to use this surgery. Otherwise, so this is the one. Next one is the in-toe gait. So basically, it is a pigeon-toed gait. So once the patient will walk in this manner, so this is midline. So from the midline, if we make a axis of the limb, axis of the foot, this is the footprint. So normally there is a foot progression angle. This is the foot progression angle, is the angle between this the midline and also this axis of the foot. So basically, normally it should be 6 to 10 degree. But if it is less than 10 degree, less than 0 degree, it is an in-toe gait. So it is going towards the midline or just opposite to the midline. Or if it is more than 20, it is the extroverted, external, that's the exttoe gait. So it is the in-toe gait if it is this foot progression angle is less than 0 degree. This is most important. So this is the in-toe gait. Demography, it may be related with the intrauterine position of the crowding of the limbs, usually detected 3 to 4 years age. When the when the baby starts walking, the spontaneous correction can be possible in 10 to 12 years age, may be asymptomatic, or the complaint of the anterior knee pain or frequent tripping, and that requires attention of the clinician. Now, what is the cause? Most of the cause of the introgate is the increased anteversion of the femoral head. From above down, this is anteversion, internal tibial torsion, and the metatarsus adductus, among which all the three conditions may recover within 10 to 12 years. So we have to wait up to 10 to 12 years, whether it is spontaneous recovery or not. Now, how to clinically diagnose with increased anteversion, internal tibial torsion, or the metatarsus adductus? Is in increased anteversion, the baby will sit like a W pattern, and the hip internal rotation is increased at the cost of restricted external rotation. Craig test is positive. That is, you have to, if in the prone position, if you rotate the hip at a certain, after we have to rotate hip until the greater trochanter is maximally palpable on the lateral side. So we have to check it that is the position where the rotation is maximum, and we can identify it is abnormal rotation, abnormal internal rotation. This is the correct test, and it's a great progression angle I've already discussed. So it should be zero, it should be more than, it is more than minus side. This is less than 0 degree. Internal tibial torsion is easily identified with the abnormal thigh foot angle. I've already know what is that. Now, metatarsal adductus basically is the forefoot adducted. If you see from the back, there will be too many toe sign medially. And you have to, if you check the foot border profile, there's a concave medial border. So that is the basically metatarsal adductus. If it's a concave lateral border, that is a pes planus. Femoral anteversion, basically, how to treat it. Normally, advert, the femoral anteversion remains 40 degree. It's reduced to 10 to 15 degree at the maturity. Now, classification, it may be physiological, it may be pathological. So physiological is normal, advert 40 degree going reduced to 10 to 14 degree naturally, but it may persist it more than, and that is basically it is idiopathic. But if it is a pathological, normally the physiological usually corrects within 10 to 12 years of age. So basically it is a idiopathic that may persist it more than 10 to 14 degree, 15 degree, but that may be, that no cause may be found. So that is a idiopathic. And pathological, basically it causes the hip instability. So what are the causes of the pathological increased femoral anteversion? This may be, there is cerebral palsy, it may be polio, it may be spinal dysraphism, or it may be DDH. So these are the conditions. So these are the underlying conditions. So we have to identify. So if there is an underlying condition in some diseases, we have to address those diseases first before touching the femoral anteversion. And lastly, the retroversion. Yes, it is also maybe possible in obese adolescents with slip capital femoral epiphysis or the developmental coxa vara. So this is the introductory slide. You can write it down. Now, management of increased anteversion, the clinical features are already discussed. The management depends on the age group. I've already told it may be there is a chance of spontaneous correction between 10 to 12 years age, or it may persist after 10 years of age. So if it is below 10 to 12 years, we have to check these parameters. If the internal rotation is more than 80 degree and external rotation is less than 10 degree, that can lead to proximal, that can lead to hip instability. So we will be very much careful. So if these factors are absent, we have to go for the observation. But if these factors like increased internal rotation at the cost of restricted external rotation, and also there is some it may be compensated by this increased internal and anteversion, that if it is compensated by external tibial torsion, so that is known as the miserable malalignment syndrome. And that is basically the compensatory, the natural compensation. Nature tries to compensate by external the torsion of the tibia, and that can lead to anterior knee pain. And that anterior knee pain that may be related with the patellar instability. So these are the factors you have to check if it is above 10 to 12 years age. If these factors present, we have to go by the surgery. So if in this condition, that is internal rotation is more than 80 degree at the cost of a restricted external rotation 10 degree, then we have to check these two factors, whether the proximal physis is open or closed. So if it is a proximal physis is open, we have to go by the corrective intratrochanteric derotational osteotomy of the femur with blade plate fixation. But if the proximal physis is already closed, in that case, we can go by the antegrade nailing. So otherwise, that can lead to damage of the proximal physis. But at the same time, if there is hip instability, we can add the hip stabilizing procedure. Next, if it is a miserable malalignment syndrome, we have to go by the another parameter, is a patellar instability. If there is no patellar instability, we go by the corrective derotational osteotomy like this, as we all just discussed. And for the external tibial torsion, we have to add the supramalleolar rotational osteotomy. But if there is a patellar instability is already present, we have to add the patellar realignment along with the suprapatellar femoral derotational osteotomy and also the supramalleolar rotational osteotomy. So this is the flow chart, can easily put it down. So everything will become covered like this. Spinosagittal balance. Spine should be well balanced before babies, and all of you know, when there is a flexion deformity of the femur, that is easily compensated by the spine, basically the lumbar spine, by hyperlordosis. So how it happens, and through this topic you can easily understand how it happens. So it depends on the curve. So the spinal balance depends on the curvature of the spine and the position of the pelvis, that is sacral tilt. It indicates the degree of compensation of the hip deformity by the spine. In presence of inadequate compensation, patient becomes symptomatic. If there is no compensation, any type of hip flexion deformity becomes revealed, and there is awkward gait, and that can lead to severe pain in the hip joint. Ultimately, may lead to degenerative arthritis. So, and how it can be measured? It measured by radiologically. So this is the technique. It is their procedure. There's Hueset and Hueset et al. 2019. How to take the radiograph patient, they will ask the patient to stand in an erect posture with both the limbs in this manner, in a very resting manner, and stand in standardized erect posture, and the whole length radiograph of the spine is required, and then epi view as also the lateral view. And you have to check this. This is a pelvic inset. This is the sacral tilt. You have to check the pelvic incidence. What is pelvic inset? So this is the sacral tilt, and this is the femoral head shadow. And one point is it is center of the femoral head is connected with the midpoint of the sacral tilt, and if this is the right angle to this, this is the sacral tilt, and this line is right angle to this, and this is this line and the right angle to the sacral tilt. This is known as the pelvic incidence, and this angle is known as the pelvic tilt, and this is the sacral slope. So basically, these are complementary. If the sacrum goes on the goes back, there's a much more tilt. So if this reduces, this pelvic tilt increases. So basically, the pelvic incidence is basically the sum of sacral slope plus pelvic tilt. So basically, the normal value is 52 degree. Now, basically, so if the knowledge is, if the pelvic incidence is much more, there's the patient has a high chance of compensation. The lumbar vertebra can compensate much more. So that is most important. Now, in the lateral view, how the flame is it is drawn. A plumb line is drawn from the C7 downwards. Normally, it passes through the posterior corner of the sacrum. So this is the C7. So normally, if it is a plumb line, it is drawn through. Normally it should pass through the posterior border of the sacrum. So it is a normal one. But if it goes anteriorly, so basically it is a positive balance. If it goes on the back side, it is a negative balance. So basically, this is the sagittal balance. And another is the important is the spinosacral angle and the C7 SFT radio. What is that? So this is the lateral radio of standing radiograph. So this is the femoral head. So this is from the femoral head, the vertical line is drawn from the femoral head, and this is the normal plumb line is coming from the C7. Okay, it should go normally. It should go through the posterior part of the sacral border. So this is the difference. This is the difference between is the sacrofemoral distance. This is sacrofemoral distance, and this is basically. This is normal plumb line, and this is the normal plumb line is little bit posterior. So this should be the normal side. So this distance is the SC7D. So these parameters divided by these parameters is most important, and this basically denotes the sagittal balance. And normally this balance should be minus 0. So little bit posterior. But if it is going anteriorly, that can lead to some much more pressure on the posterior side, and that can lead to arthritic changes and little bit pain. So in case of, if it is a degenerative disc disease, as you can see here, see, there is a loss of lumbar lordosis, and this C7 plumb line goes anterior to that. So this is a positive side. So that can lead to severe pain on the back. Similarly, that can happen also in the disc prolapse. This disc prolapse is going on the back. So there is a loss of lumbar lordosis. In both the conditions, see, the pelvic incidence is less. Whereas in case of degenerative spondylolisthesis, pelvic incidence is much more. So that is how in degenerative spondylosis, little bit the patient becomes much more symptomatic for a long time. So that is the technique. So if it's a greater lordosis, that generates much more amount of forces on the articular joints, posterior articular joints, and they cause severe pain. Whereas the posterior arthritis has a marked inclination of the vertebral end plate, and is a significant predisposing factor to slippage. So this is the last topic of today. So basically, the prosthetic foot can be divided into the conventional foot, ESR foot, that is energy storing foot, and the bionic foot. And the conventional foot, the ESR foot may be the early, advanced, and articulated. Bionic foot may be stabilizing and the propulsive. So how to differentiate the Sach foot from the Jaipur foot? You can see here the Sach foot, and basically it has both the Sach foot and the Madras foot both has a keel. There's a wooden keel. So there is a less activity on the ankle side, and they can be compensated with the help of the microcellular rubber. Whereas in the Jaipur foot, there are 3 types of microcellular rubber. It is covered with the vulcanized rubber, and this each component is separated from each other. So that is how that can, once they compress, that will simulate the dorsiflexion and plantar flexion. And because of the 3 pieces of the microcellular rubber, they can also give some transverse sliding movement. And then that will be helpful for walking on an uneven surface. Not only that, because of this good aesthetic design, that is much more acceptable to the villagers, and that is how it is much more cosmetically acceptable. So Madras foot basically how to differs from Jaipur foot. It has a wooden keel. Sach foot, Jaipur foot doesn't have a wooden keel. It has a Madras foot is a convex rubber, hard rubber, soft rubber. There are different types of rubber. Hard and soft rubber, they are alternative hard and soft rubber. They are attached with some glues, and there is some suede leather. It is outside. Suede leather is outside. So if we compare these, Jaipur foot is much more beneficial. It is efficient in providing the lightweight, comfortable, durable, artificial fit for the rehabilitation of the physically challenged and the handicapped. Jaipur foot has been proved to be the grounds of the material properties like hardness, abrasion, tensile strength, relative density, resilience, and hence outweighs the Madras foot and the Sach foot in composition and performance as well, be it comfort while walking, be it leisure exhaustion rate, and be the occupation retrieval rate, be it aesthetic, and be it a social cultural acceptance. So in this manner, so how again I'm concluding. So we have to make sections and subsections. We have to keep your left side of the page white. In that case, we can write the main heading, section heading, and some schematic diagram. On the right side, we can write the main sentences. In between, we have to give some schematic diagram, some flow chart, and also the tables. Thank you. Over to Janki.
Thank you so much, sir. Sir, we have 2 questions in the chat box. Dr. Anuj has asked, what are the effects of high tibial osteotomy on tibial slope and patellar height?
Yes, basically the high tibial osteotomy, that basically what is it shifts the mechanical mechanical loads from one side to other side. So that is basically it causes the different changing of the pressure on the inside in the articular surface. So if the change, why it is done? So in case of grade 1, grade 2 osteoarthrosis, so there can lead to it can be sufficient enough for changing the mechanical axis, change the mechanical axis. So if in normal tibial slope, it is say 3 to 7 degree. So in that it can definitely protect the medial compartment. So basically this is that is how it can protect the tibial slope. Tibial slope is very important because the osteoarthrosis first it affects the posterior compartment. So initially the joint space reduction starts from the posterior compartment and coming gradually on the anterior compartment. That is how the PA view is required PA view in a 30 to 45 degree flexion is required to identify the reduction of the posterior joint space. And the true lateral view is required for the tibial slope. So that is how it is in grade 1, grade 2 osteoarthritis, where there is a not significant damage of the posterior slope. So in that case, if you shift the mechanical axis, that will protect the tibial slope.
So I think there are different ways where you can actually change the slope when you do your osteotomies. Okay, so depending on so when you're doing the closing wedge, it probably isn't that significant, but when you're doing the opening wedge osteotomies, you have to be careful that the posterior part of the tibial medial corner is cut adequately with the saw, because if you don't, then it tends to increase the posterior slope, because the posterior part will not get distracted as much as the anterior part. Okay, so that's something. You can also play around with the slope depending on if there is some element of ACL or PCL insufficiency by increasing or decreasing the posterior slope. So I think there are various factors which come in. If you do the osteotomy below the tibial tuberosity, then you are not affecting the patella height. If the osteotomy is above the tibial tuberosity, then you will be affecting the patella height. So these are things you need to take into account when you're doing your osteotomies.
And so for the that, because the osteotomy at 2 places in that one. So what the biplanar osteotomy, sir? So what is its bearing on the patellar height, sir?
So that's what I said. So when you're doing the standard HTO, you are taking the cut above the patella insertion. So the oblique cut goes above the patella insertion of the patella tendon, above the tuberosity. So if you increase it by a lot, you will affect the patella height. Okay, so when the angle is more than 15 degrees, suggest that you actually take the oblique cut down so that you're distal to the tibial tuberosity, then you will not affect the patella height. Okay, but that's something which you have to decide before you do your osteotomy.
So another question is asked about the recent advancement in the management of adolescent idiopathic scoliosis.
Yes, I've already shown it. So in adolescent idiopathic scoliosis, that can be treated with the help of the 2 components, either anterior and the posterior. So if there is a large curve, in that case we can do both the combination of both the anterior and the posterior. In both the combined curve, the anterior curve is used to reduce the total area of fusion. So in that case, only the apical vertebra, and also the central part of the one curve. Suppose there is a double curve. So in that case, both the anterior and the posterior is used. And whether anteriorly, only the apical and the central part of the vertebra are fused, so that the total number of vertebra is less number of vertebra is got to become fused. Now come to the posterior side. In posterior side, we have to go by the posterior instrumentation, the osteotomies of the facet joints, as also the instrumentation. I think there's both the combination is a recent advances. So in that case, we have to fuse less number of vertebra. Previously, it was considered that the whole the end vertebra from above down, all the structural craft should be fused along with this. But now the recent advances can fuse the most unstable curve, depending on the sagittal balance. The lower curve, we have to fuse absolutely. In the upper curve, we can observe, or we can go by the anterior approach. We can fix mainly the central vertebra.
So what has changed is actually in the management of the pediatric or juvenile or the infantile curves, where you have fusionless surgery, where you have growth rods, so they get distracted as the child grows, and you don't fuse them until later. That is one of the things that has become very popular.
That is the, yes,
Yeah.
for the mature patients, not for the adolescent.
Yeah, that's for this younger patients rather than the adolescent patients.
Telescopic rods are used.
But, I mean, you want to fuse less, as only the essential segments are fused where possible. You need to get the sagittal balance corrected. Those are the few principles that you have to go by when you're doing scoliosis surgery. Okay.
So, Dr. Anuj has also asked about one question which was asked, operation theater etiquette and universal precaution. And his one more question is, difficult one was asked that what is rocker horse effect of total shoulder arthroplasty and how do you manage this effect?
Yes, that is a very good question. I think there are several important questions are there, but it is because of the dearth of time I couldn't discuss about it. Actually, rocker's horse effect is basically this rocking horse, like the children, those who are riding on a toys of the horse and looking like this, there's leaning forward and back like this. Basically, the humeral head is a large in comparison of the curvature of the glenoid. So basically, it is extremely important to make a concentric reduction on the glenoid, the constant reduction of the humeral head on the glenoid. And how normally all the rotator cuffs, they are managed from front, from side, from back. They are arranged in such a good manner by naturally they will maintain that normal concentric movement. But if the rotator cuffs are torn either before operation or during the operation of total shoulder arthroplasty, so what will happen? So that this concentricity of the reduction, concentricity of the movement will become lost. So in that case, the humeral head is going either going riding up commonly or riding up little bit distracted lowerly in the lower component of the glenoid. So in that case, so that there is no concentric movement, but there is the point contact movement like a single like a rocking horse effect. That is known as the rocking horse effect. If there is a damage of the rotator cuff, which will maintain the concentric movement. So in case of that can happen before operation or during operation. So there is or even after the operation, if they're not working, they're not properly rehabilitated, that same thing can happen. So in that case, so there is a point contact instead of concentric movement, and on point contact, the humeral head is moving like this rocking horse effect over the glenoid. So what is the effect, ultimate effect? So in case of total shoulder arthroplasty, if there is a point contact pressure on the glenoid, ultimately the glenoid will become gradually loosened, and ultimately there may be a failure of the glenoid component. So that is the main reason, and we have to identify. Before that, if it is already occurred, then we have to treat by revision and by reverse shoulder arthroplasty. So basically, this is the treatment of choice.
So there was a question on universal precaution. So I think that should be clear to most people who are involved in surgery, is that whenever you have patients where the staff is at risk if they have a needle stick injury or anything else, you need to take certain precautions in terms of the draping, the gown, using disposable material for everything, special protection for the surgeons, including double gloving, eyes, protection for the eyes, etc. And if you also need to have the necessary available treatment for things like, if you have a needle stick injury in an HIV patient, you need to have the immediate treatment that you need to have immediate available at site, on site. Okay. You also have the OT discipline in terms of how everything is kept within the OR and disposed together. You don't walk out with the sort of protective covering outside the OR, okay? All that is removed inside the OR before you go out, okay? And kept in special containers, and which are disposed straight away. So those are the basic issues that are there in any universal precaution system. So if you have HIV, hepatitis, all these other things, they are all of them have to have this kind of universal precaution for the surgery. Okay. Anything you want to add to that, Ananda?
Yes, yes. Like the sterilization, during sterilization, you have to choose the specific instruments for specific sterilization. During the lead jackets, and also the batch, that radiation batch. If it is a radiation, if it is a Shyam OT, then you have to keep some specific light outside once it is on. So that is one. Next is the adequate precautions of this preservation of the lead jackets. This is also important. If there's a
so those are parts of the OT sort of discipline, etc.
Yes, yes.
What I was talking about is universal precaution, which is basically for patients who have either HIV or hepatitis and things like that. So where
for HIV, yes, there are some specific type of gloves.
That's right.
Yes, that can be used for that, at least 2 or 3, and specific donning and doffing of the garments.
And then again, the OT has to be then either fumigated or whatever method you use to this thing after the use before other cases come in. Okay.
Yes, and there are 2 school of thoughts. That is, one is that we are suggesting that if there is some HIV positive or hepatitis B, that sort of operation should be done in an earlier part of the day, so that everybody will become very much alert. And after that, we have that at least at half an hour to 1 hour period should be absolutely free for complete sterilization. That is there's some schools of thoughts, and another school of thoughts is the conventional classical. They are telling that should be at the end of the day after the cessation of all.
Yeah, so I think it depends on the surgery as well. So I guess if it's a total hip replacement, then you might do it a bit earlier. If it's an infected case, you'll do it later. So those are other factors which come in. But by and large, what you need to be aware of is that the OR has to be cleaned thoroughly again before another case. So you have to give enough time after that case for the OR to be properly and adequately cleaned up, if necessary fumigated before the next case comes in.
So another question is how will you remove the broken nail? Isn't it? Broken nail. There are several ways to remove the broken nail. That depends on which part of the nail is broken. So it may be broken above the fracture, and also it depends on the status of the fracture, whether the fracture is united or not. And then another is whether these 3 points. One is the level of the nail is broken. Next is whether fracture is united or not. And the third one, whether the nail is straight or bent. That is also important. And fourth is if the screw is also broken. So the nail plus screw, both are broken. So depending on that, you can classify it. If the fracture is not united and the nail is broken, so your job is relatively easier. And then we can remove in any part. So you can go through the fracture site and can get taken in part. Otherwise, if the fracture is united, then there's a question and there is no screws are broken. So that is the main problem. So in that case, you have to remove both the distal screws first, followed by the keeping the first initial at least one proximal screw. You have to use your different the removal set. If it is removed again by this method, it's okay. Otherwise, you have to make a jam pack with some guide wires inside it, and then take all the bunch of the guide wires can be held with the help of a vice, and we have to take it out. That is one. Otherwise, it is very rarely, if it is very much stuck in a very constricted part of the bone, it is united, then you can make a bone window. That is one. And lastly, if it is a bent one, so bent one is very difficult. If it is a fracture still not united, you can cut the bend to the fracture, and then you can easily take it out. Otherwise, if fracture is united, then there is a very difficult situation. In that case, somebody may try to straighten it out. I don't know whether it will be advisable or not, but somebody it is successful, or otherwise you have to remove by make a bone window and cut it and take the brisbane piece and have to make a fresh application of an internal fixation, I think. Anything to be added, sir?
That's okay. I think there was a question about classification in the DNB theory. Whether you should be writing it or not for fractures, because apparently they do not ask for it in the question.
Classification is not a big issue, but if you classification means any fracture like the pelvic fracture, any type of classification. Suppose there is a proximal tibia fracture. Sometimes it may be asked what is the current classification system of the proximal tibia fracture.
No, where it is not asked.
So is that fetch any marks that he is asking if he will write the classification if it is not asked in a question which is to describe a fracture or management? Then if we are writing the
Yes, so
classification with that.
Okay, I have got the point. Actually, the management depends on the classification, isn't it? Suppose there is a management of proximal tibia fracture. So unless you write the classification, how do you write the bits management?
Yeah, I think where it's relevant to your answer, you should write it.
Yes, definitely.
Okay.
Yeah.
So I think we
One
should.
last-
Sorry?
Last one, sir. Dhananjay Patel has asked about the all outside technique of meniscus injury. That one.
Come on, that's a
Yeah.
sports medicine question. Okay.
Yeah.
I
What-
think that's a
what is the
technical question. He should ask his arthroscopic surgeon about that. Okay. So, right. So I
Yeah.
think we'll call it a day. Thank you very much, Dr. Ananda. As usual, excellent presentation and good discussion of questions. I think we should carry on. I think we have another meeting coming up
Yes.
right
Yes,
after. So I think we'll have to call it a day now. Okay, bye.
Okay.
Thank you. Thank you very much, sir.
That's the OSCE in next class.
Yes, sure, sir. Thank you, sir.
Okay, so
Okay, bye.
bye.